Camp TV thanks you for watching this presentation. We'd love for you to become a member and use your creativity at our station. Please visit hinghammedia.org or call us at 781-836-5094 if you'd like to learn more.
Thank you so much, Dawn. Oh my gosh, it's such a pleasure to be with you. And those of you that just braved the weather out here, you get extra credit. I'm sorry for that. But I want to thank Dawn and Llewellyn and South Shore Action, Sneakers Laced Up, and Derby Academy for this chance to meet with you. It's a real pleasure, and especially to talk about an issue that I feel so passionate about. Representative Machino, thank you very much for sharing your time with us. So here's what I'm going to try to do. I'm going to talk about the big picture first in healthcare. Why did we end up where we are? What's going on? What was the shape of American healthcare before President Obama came into office? What's the Affordable Care Act? What did he try to do? What is now happening in the Affordable Care Act as literally as we speak in a Congress that is oriented to try to take it down? But much more important to me, I'd like to contextualize that whole drama in terms of the American project and what we are as a nation and what our values are. Because I think although issues fascinate me and fascinate you, as do identity politics, that is not the point here. This is not a time in our nation when I think issue politics is what matters as much as values do. And I'm going to actually try to close that loop for you. I'll try to do it efficiently to leave time for you to ask questions. And you know, if it's okay with you, Dawn, let's invite you to interrupt me. I know you from my campaign trail, you're not shy. Don't be shy here. Interrupt me, have at me. If you disagree with something I say, tell me. And if there's something that isn't clear, interrupt me and I'll try to make it clear. But I want to start back with values. There's a quotation I've been using recently that I ran into from Abraham Lincoln. This is from the first major speech that Lincoln ever gave. He was 28 years old. It was January 27th, 1838. And he gave a speech as a 28-year-old at the Young Man's Lyceum in Springfield, Illinois. Maybe you've heard this excerpt. This was in the wake of episodes of mob violence in the area and the death by burning of a black man in St. Louis. And this, in part, is what Lincoln said. He said, "Shall we expect some transatlantic military giant to step the ocean and kill us at one blow? Never. All the armies of Europe, Asia, and Africa combined could not, by force, take a drink from the Ohio or make a track on the Blue Ridge in a trial of 1,000 years. At what point, then," he asked, "is the approach of danger to be expected?" He said, "If it ever reach us, it must spring up amongst us. It cannot come from abroad. If destruction be our lot, we must ourselves be its author and finisher. As a nation of free men," he said, "we must live through all time or die by suicide." Strong words, but they provide me the foundation for what I want to share with you, not just about healthcare, about the overall directions here. We're going to have to do something. Healthcare is ground zero right now, or among the ground zero for the confrontation that we're seeing in this country between, I think, what we call progressive values and other values. So let's go to healthcare first. And I'm going to try to explain what might have been on President Obama's mind when he took office in 2008. What he knew was that the healthcare enterprise in our country, a sixth of our economy, was not functioning well. The most important charismatic element of that was that people couldn't get care. They were not covered. We're the only developed democracy on earth that doesn't make healthcare a human right. Some do it explicitly, some do it implicitly, but no other country leaves people out. We do. We leave 50 million people out as of the time Obama was elected. And that's part of the story. The rest of the story is wonkier. I warn you, when I was campaigning, everything had to fit into 7 minutes. But now I'm not campaigning, and I'm an academic, so there's going to be a little bit of a longer riff here, but basically the other thing going on with healthcare in our country, and it's true in other countries, is that it doesn't work right. Not only can't people get it, but when they do get it, there are defects. There are quality defects. The defects were actually brought to the fore by the National Academy of Medicine, the Institute of Medicine at the time, in 1999 and 2001. These are reports that I helped write. I was on the committee that wrote them. But the report To Err is Human in 1999 was about errors in care. How many people here have noticed or been subjected to an error in your care? Something went wrong, and maybe someone got hurt, a loved one, you did, some mistake, some error. Well, it turns out most people have that exposure, and it's lethal. 44,000 to 98,000 deaths a year in our country from injuries in care, safety problems. The subsequent report 2 years later, called Crossing the Quality Chasm, broadened the terrain and said we got problems in 6 dimensions. And the dimensions it laid out were safety, people get hurt, effectiveness, cares are unreliable. The care you get if you have a migraine headache or a heart attack or even a cancer, it varies enormously just depending on your zip code. There's this randomness about what care is. We never standardized it to science. Patient-centeredness, it was the 3rd dimension the National Academy pointed out, and it was like indignities in care and not respecting people's wishes or their ethnicities, their languages, their needs. The 4th was timeliness, delays. Healthcare is the only industry that's founded on waiting rooms, basically. The 5th was efficiency, loss of money because we don't do things right. And the last was equity, probably should have been first. In the United States, it's still true, the biggest predictor of your lifespan is your race. A black child born in Baltimore, a male, has a life expectancy 8 years shorter than a white. There's 15-year difference in life expectancy from the poor to the wealthy areas of the cities in our country, 15 years. As if that weren't enough with these quality problems, the other problem was cost, because we spend much more money than any other nation on earth on healthcare. There's no one even close to us. It's 18% of our gross domestic product. This is a complex diagram from OECD, the Organization for Economic and Cultural Development, which is a membership organization of 39 countries, and they publish data. These are OECD member countries, and this graph is a little complicated. This is life expectancy, average in the country, and this is cost per capita, how much money they're spending. And most of the countries on earth are on this curve here. Here's the US. Double the expenditure per capita, and nowhere near the top life expectancy, not even close. We're something like 40th in the world. The consequences are real, and they're related to the Affordable Care Act, to the agenda that Obama brought. The consequences of this kind of defect is that healthcare bleeds resources from other parts of the economy. When I ran for governor, I worked with the Massachusetts Budget and Policy Center, nonpartisan support system. This is the Massachusetts budget for different categories of expenditure. And basically, over 15 years, 2001 to 2015, everything's down. Higher education's down about 30%, early child's down about 30%, parks and recreation 25% down. You name it, every budget category in real dollars went down in a decade and a half, except one, and that's healthcare. That's up 72%. And you don't want your taxes to go up, nor do I. So what's happening is a transfer of wealth, of opportunity from other things to healthcare. And it affects people. This is a kid I met when I was campaigning. He's from Holyoke. His name is Gorje Sanchez. He was 20 years old when I took these photos. I was visiting him at the SSYI program, the Safe and Successful Youth Initiative that Governor Deval Patrick started with $10 million funding 11 centers around the Commonwealth to give people like George, who were incarcerated, a chance to get back in society. George was the 10th child, one of 10 kids in a single-parent family. His father raised the family, the mother ran away in Holyoke. Holyoke has half the median income of the rest of our state. He didn't make it. At 12, he was on the streets. 14, he was in trouble. At 16, he was in jail. Excuse me, at 18, he was in jail for robbery. He was 20 when I took his photo. He's out of jail, and the SSYI program is giving him his GED degree. It's giving him mental health counseling. It would give him substance abuse counseling. He doesn't happen to need it. It's providing some child care for his girlfriend's child, who he's holding here, JDL. If you're in SSYI, your chances of going back to prison are 15%. Without SSYI, in Georgia's demographic, the chance of going back to prison is 85%. I don't need a drug that effective. And yet, at the year I ran for governor, the SSYI budget was cut by 50%. Why? Because healthcare was taking the money. That's one way to think about it. So we have a coverage problem, we have a cost problem, and we have a quality problem. It's national, it's not just in Massachusetts. When I took over CMS for President Obama, I brought this set of goals called the triple aim: better care, better health, and lower cost. Better care for individuals, no injuries in care. Why should we have them? Better health, let's work not just on treating heart attacks, but preventing heart attacks. We can do that. And lower cost by reducing waste. The levels of waste are phenomenal. They're estimated to be about a third of expenditure. We spend $3 trillion a year in healthcare. About $1 trillion is waste. We can do it. We can do it as a nation. There's no reason we couldn't redesign, re-engineer a care system. We could do it in Massachusetts. And had I been your governor, we would have. There's a chance to make this state reasonable for quality, cost, and health. We know how to do it. I can show you. I mean, I spend my career now working with organizations that do it. This is one of the best. This is the NUCA system of care in Anchorage, Alaska. It's the care system that is owned by and operated for 60,000 Alaska Natives in the Anchorage Bowl. I lived in Anchorage for a year and a half. My wife had a sabbatical there, and I lived and worked in this system, and I know it very well. NUCA was started in 2002 in its current form with basic principles of design. I can't go over all of them, but it's team-based care, it's prevention-oriented, they use spiritual healers in the community. They don't want you in the hospital, they want you out of the hospital. The hospital doesn't try to stay full, it tries to stay empty. It's redesigned care, it's triple aim care. And it's all team-based. This is the doctor's office at NUCA. You're looking at a doctor, but you're also seeing a nurse practitioner and a behaviorist and a nutritionist and a physiotherapist and a pharmacist. Everything's teams. And the results are phenomenal. Just look at this is what they did in 5 years at NUCA. A 53% decrease in hospital admissions. They halved hospital admissions in 5 years. A 65% decline in use of specialists. They don't need the specialists. There are resources in the community. Even a decrease in primary care use. And everyone's happier. The patients are happier. The quality scores are through the ceiling. I could spend all my time on this kind of stuff. This is the wonk world that I live in, but it's how do you make healthcare what it should be, what it could be. And we can do it. So you're President Obama. You come into office in 2008. The federal budget's being bled by healthcare just like the state budget is. You have the evidence about quality of care. You're going to appoint Tom Daschle at that time as HHS Secretary. Tom Daschle wrote the book on quality of care. He's an expert from Congress on that. You know about health status in the population, and frankly, as a person of color, you know about the erosion of spirit and possibility in the vulnerable communities in our country, and you want to do something about it. He could have chosen something else to do. He could have worked on an energy and environment. That would have been a great thing to work on. He could have worked on the vitality of our cities and housing and roads. But in a way, he chose healthcare as a threshold issue. It's a test of the character of our nation. Will we make healthcare a human right in our country? That's the question he raised. His advisors advised him not to go there. Too hard. Others, back to Teddy Roosevelt, had been trying to do reform. He said, look what happened to Hillary Clinton in the Clinton years. Don't go there. He said, we're going there because we have to, and hence the Affordable Care Act. Now, the Affordable Care Act. When I took over Medicare and Medicaid, the Affordable Care Act had passed in March of 2010, and I arrived in Washington in July of 2010. And my job through CMS was to implement 70% of the Affordable Care Act. So it's a law I got to know pretty well. And I don't want to put you to sleep, but I'm going to explain what it tried to do, because what it tried to do is what the Republicans are trying to undo now, and you really can't understand what they're understand what this law is trying to do. To do that, I got to give you one other piece of wonk information. So, gosh, I really am going to put you to sleep, but we in America pay for health care all sorts of ways. As you know, when I ran for governor, I came out favoring single-payer health care. Partly it's because of the immense complexity of the way we do it now is just costing us a lot, but it is complex, and here's how it works. About 150 million of us get our health care coverage through our employer. We're an employer-based system, 150 million. 70 million of us get it through Medicaid, either because we're low income or we're disabled, and we're either in nursing homes, which is half the Medicaid expenditure, or just for health care, that's about 70 million. 50 million people get their coverage for Medicare. If you're over 65 like I am, you are in a single payer system. That's it. Government, I paid my dues up front, and now I get health care. About 8 million get it from Department of Defense, 8 million from the VA, 8 million kids get it from the Children's Health Insurance Program. But if you added up all those numbers, there'd be some left out. They don't have coverage from their employer. They don't have coverage from Medicare and Medicaid, but they want coverage. Who are they? They're called the individual and small group market. They're onesie twosies. They're artists. They're people who work in bakeries. There are people who don't have a job right now, but will. They can't buy the insurance through an employer. They don't have one. They're not eligible for Medicaid. They're not eligible for Medicare. That's 20 million people. It's called the individual and small group market, 20 million people. There's a big problem there because the insurers don't want to cover them. And if you think about it, if you're an insurance company, you wouldn't want to cover them either. They're high risk. They come in onesies and twosies. There's no economies of scale. And that's a big problem. How are we going to cover these people who have no other way to get coverage? And many of them are low income. They're not dead poor, but their incomes are $50,000, $60,000 a year, and healthcare costs about $20,000 a year for a family. So they can't get it, and that's one problem. And then there's Medicaid. What's Medicaid? Well, Medicaid covers people of very low income in the country, either in nursing homes or in earlier years of life. Medicaid is a state-federal partnership. It's not like Medicare, which is federal. It's a partnership. And under the law that set up Medicaid in 1965, each state can choose who's eligible. So Massachusetts said long ago, you're eligible up to 138% of the federal poverty line, the federal poverty definition, which this year is $24,000 for a family of 4. So you can earn 138% of that, and you can be in mass Medicaid. Alabama said, you're not eligible for Medicaid if your income exceeds 16% of the federal poverty limit. 16% of $24,000. So heck of a lot of poor people in this country, in the states that weren't as generous as Massachusetts, didn't have any coverage. They're not employed. They're very poor. They're not old enough to be on Medicare. What do we do for them? And that's where President Obama set his sails. He said, we're going to level things out. And let me walk you through the Affordable Care Act now. It's actually 2 laws. It's in one. The first, it's not technically 2 laws, but that's how I think about it. The first part is a whole bunch of stuff to make insurance better by covering more people and by making sure that when they get the coverage, it's meaningful. It's real coverage. It's not garbage coverage. So cover more people. How did it do that? Well, number one, Medicaid expansion. What does that mean? Remember, Alabama's 16% eligibility? The Affordable Care says, no, dear country, everybody in the country is now going to be eligible for Medicaid up to 138% of poverty, about $30,000 a year for a family of 4. Everybody is. Alabama, don't worry. Between 16%, which is your level, 138%, which is this level, the feds pick up the difference. The federal government will cover the gap between what the state decided to cover and what the country now is deciding to cover. Completely for 3 years, and then it goes down to 90%. That's Medicaid expansion. And the law said, dear Alabama, either expand with our money, federal money, or you're out of Medicaid completely. You get no Medicaid. The Supreme Court said, nah, you can't do that. The Roberts Court ruled against that and said you can't require Alabama to expand. They have the choice. They can stay in as they currently are, or they can expand. And as it turned out, I think it's 31 states expanded, and 29 didn't. But hey, that's some progress. If all of the states had expanded, that's 16 million more people would have been covered. Very poor people would have been covered, and people in nursing homes. The way it turned out, it was more like 10 million got covered instead of 16 million because that's a Supreme Court decision. And today, there are still 29 states that haven't expanded. No, excuse me, 19 states that haven't expanded. 31 did, 19 states. First thing. Second, exchanges. What's that? Okay, remember, now we got Medicaid covered, expanded. There are people with other kinds of coverage, but then there's this other group, this individual and small group market. They don't have access to care or coverage. Most of them are too poor to buy insurance, and they're not eligible for Medicaid. So the law set up these marketplaces. And it went to the insurance companies and said, dear insurance companies, you have to now post on this marketplace insurance that's affordable to people of relatively low income so they can have access. You have to give it to them. You can't deny it to them. Even if they have diabetes, even if they have had a heart attack, you can't say no. Before that, 110 million people had pre-existing conditions and had trouble getting health care, especially if they were in the individual market. This ended that and said, insurance companies, you have to issue the policies. And we're going to subsidize the cost of the policy. Why? Look at the price of your policy. If you're now making $50,000 a year, you're a family of 4, your insurance is costing you about $20,000 or $22,000 a year. You can't afford insurance without some help. And so a sliding scale subsidy was introduced to help people get it. And if that went well, another 16 million get covered. 32 million Medicaid plus exchanges. Here, the states didn't play. Some didn't. The same ones that didn't expand Medicaid in many cases said, oh, we're not going to set up an exchange. And the law said, well, the federal government would then set up an exchange. And they did, but the states weren't marketing things, they weren't helping. And so the exchanges didn't enroll as many people as had hoped. We hoped for 16 million, we got about 8 million. And that had to do with lassitude on the part of the states that didn't expand. Now, in order to make that all work, you need these 3 things. I told you, guaranteed issue. You have to tell the insurance company, you have to give a policy. You can no longer deny an American a policy. But of course, that would raise if I had to give someone with a heart attack a policy, I'm going to make it a very high price policy because they're probably going to have another heart attack. And the law said, no, we're going to do community rating, which means everyone's going to be in more or less the same pool. We pool people together, well people and sick people, under the Affordable Care Act and the exchanges. That keeps insurance affordable for everybody. And the last thing is the hated individual mandate. What's that? Well, as Massachusetts showed in 2006 when it passed its law like this. Suppose we do everything I just told you, and I'm 28 years old, and I'm immortal, and I'm not sick, and you now have guaranteed issue. That means when my car hits a tree, I can buy insurance then. I don't have to buy it now when I'm well. It's guaranteed issue. I can wait. And the law said that's not right. Everyone's got to be in the pool, so you can't wait. Everyone's got to bear some of this cost. And so in America now, either you get in the pool, 28-year-old, or you pay a penalty. Not a big one, but enough to make you think twice. And that's this guaranteed issue, community rating, and individual mandate. The other thing that you all know if you have college-age kids under 26 came under the parents' policies under this law. That's about 3 million people. Add it all up, we could have covered 32, 35 million more people of the 50 million with no coverage. It didn't go perfectly because of the Supreme Court decision and because the states were not enthusiastic about adopting the exchanges. The second part of this part of the law is better coverage, a bunch of requirements. Like this law requires insurance companies, Medicare, and then the insurance companies followed suit to cover prevention. Medicare didn't cover prevention, except under certain special statutes. Now, under Obamacare, everybody gets covered in Medicare for all preventive services that are effective. Every one of them. First dollar, no copay. And the private insurers said, we'll do that too. So immense, tens of millions of people got access to colonoscopies and mammographies and smoking counseling and a whole bunch of stuff that works. It also did stuff to help elders get their pharmaceuticals. That's a little more technical. That's closing the donut hole, if you know about that. And it said insurance companies, you've got a whole new bunch of rules here. For example, you can't just make up insurance policies with anything you want in them and leave anything out. Before this law passed, there were many, many insurance companies that issued health insurance without maternity coverage. There were some without cancer coverage. But no, this law said, no, there are rules now, and the rules include essential health benefits. You have to cover, it isn't insurance unless you're covering these 10 categories of stuff. That was one example. You also have to post your rates. You can't be secret about your rates. So that was the insurance law. Over here on this side is a bunch of much wonkier stuff that is trying to make the healthcare better. Remember those problems? Safety problems, efficiency problems, all the quality problems. Well, there's a whole bunch in the law that tries to change that. For example, it changes the way you get paid. Up until the Affordable Care Act, most payment was fee for service. Hospitals made money by staying full. Doctors made money by seeing patients. Radiologists make money by taking more pictures. And that just produces the American healthcare costs. This law has a bunch of payment changes that say, you know what we're going to pay you for? Outcomes. We're going to pay you if people get better, as best we can predict, given their health status. And you get to do very well financially if you're being effective in your care, and not if you're not. And all those changes in payment, these are some of their names, was what I got to implement when I was there. And you could see hospitals start to rethink what they do. Groups of doctors get together, say, how can we keep people healthier? Everything started to change. In fact, we now have the lowest hospital readmission rates in history. They're going down fast. Not in Massachusetts. Massachusetts is a laggard. But nationally, we have reduced readmissions because they're sending someone to the patient's home when they go home and making sure that they stay well and fine there. There was a bunch of stuff on transparency, so we have quality reports now. We know much more than we ever did before about how hospitals are doing, how doctors are doing. And we set up, this is CMMI, the Center for Medicare and Medicaid Innovation, which is $10 billion to reinvent care. There are plenty of places in Massachusetts that are drawing on these dollars to try to figure out a new way to care for chronic illness, a new way to deal with the opioid abuse problem, a new way to organize primary care. That's Obamacare. That's the Affordable Care Act. Pretty complicated, right? Yes. Yes, please interrupt. It's better.
I'm just wondering, when you started the conversation about the efficiency piece and the waste,
Yeah.
how does that factor in some of the,
Let me give you an example. The question is, what about deal with efficiency? Let's take ACOs and bundles. What's that? Okay. Before the Affordable Care Act, if a doctor, say, replaced your knee, okay, you get a knee replacement, how does the payment go? Well, someone gets paid maybe for doing some prehabilitation, build up your strength, the anesthesiologist gets paid something, the surgeon gets paid something, the hospital gets paid something, then you go home and you get an infection, and then someone gets paid to take care of your infection. We just chop up the payment. And that leads to very high costs and a lot of waste. The waste is administrative waste, because all the billing processes. The waste is overuse. They overdo things because they get paid to do more. The waste is failure of coordination, because then that infection brings you back in the hospital. You could have prevented it at home. That's what that waste is. That's that trillion of waste in American healthcare.
what about some of the preventative tests or the waste that happens with lots of testing that some would argue is not necessary?
That unnecessary stuff is a big bill. It's hundreds of billions of dollars a year. So now the ACO, the bundles, an ACO is Accountable Care Organization, and that it's a little complicated. It basically goes to someone that wants to be an ACO. There's a great one in Providence, Rhode Island called Coastal Medical. We have good ones in Massachusetts. Now there's a group of doctors who get together, say, we'll take responsibility for this population of patients. We've got your backs here. And Medicare says, all right, we predict the cost of care for these people next year will be so many millions of dollars. If it's lower, we'll share the difference with you. Suddenly they're starting to, oh, wait a minute. If I can save the money, I get to keep some of the money. If they don't go in the hospital, if they don't do the test. So that kind of sharing is part of the deal. Oh, wait a minute. Doesn't that mean I'm going to skimp? What if you need to go in the hospital? What if you need to test? We have quality measures. That's all this stuff. So we put it, actually for ACOs, there are 34 metrics. They have to report them. And they don't get a nickel if they don't hit the benchmarks on those metrics. So it's a whole new way to think. It's aggregating payment. It's capitated payment. It's single payment. A step. That's one example. All right, Affordable Care Act. Now, one other thing, remember the federal government's now picking up some money, tabs, right? It's going to pay for that gap in Medicare. It's going to pay subsidies for the exchanges. Remember that stuff? That costs money. So the Affordable Care Act has to raise money, and it does it. It does it a couple of ways. One is by savings. So there's hundreds of billions of dollars of lower costs, which are there. We saved the money. They're lower, very low increases compared to the past in the Affordable Care Act. But it also increased taxes. It put taxes on certain medical equipment manufacturers, on pharmaceuticals, and on people of high income. Over $250,000 a year. The top 2% paid an extra amount of money. And that raised about, overall, over 10 years, it raised about $800 billion or $900 billion, enough to cover all of this. And all of the effects of everything I'm telling you were to decrease costs in the longer run, and the CBO scored it that way. So it was shifting money from wealthier people in America to cover the exchanges, the subsidies, and so on. That was the theory of funding. Republicans hated it from day one. I was right in the firing line. I stood before Congress and got yelled at more ways than you can understand. They were very angry. I think they were angry about having a black president. And I think they were angry about a values-based approach. The call to arms that we had as a nation made them angry, but they were furious. And from day one, they said, we're going to take this away. But they couldn't until the last election. Now they have the Senate, the House, and the presidency. And job one, they've said from the start, is to take it away. What does take it away mean? Here's what they're proposing to do. This is what they call it, the American Health Care Act, AHCA. This is what came out of the House, is now in the Senate, and is being debated and tweaked in the Senate, with the Republicans hoping they can squeak something through the Senate and get the kind of Republican left, like Susan Collins and Lisa Murkowski and Rob Portman, to buy in, and the Republican right, like Ted Cruz and Rand Paul, to say yes also, and then to get a package that they can get them back to the House that the House will accept. No one knows if that's going to happen or not, but you read the papers like I do. But here's what they're doing. It changes, yeah.
Didn't the Republicans have a similar plan with Hillary Clinton?
Yes.
Yeah,
The question is, did the Republicans have a plan that looked a little bit like Affordable Care Act? Absolutely, yes. If you go back to the 1990s or even before that, what the Republicans were proposing was, let's not have Medicare for all. Let's have a private insurance-based expansion, yes. Let's have efficiencies put into the way we pay. Let's move toward value. They call it value-based payment. This, you're looking in the Affordable Care Act at a basically Republican plan with some more progressive elements to it. You're absolutely right. It was Mitt Romney that brought that plan, or at least assented to that. It wasn't his idea, but he did say yes in 2006 when we passed essentially that same law in Massachusetts and covered everybody. So here's what they're doing briefly. Medicaid expansion should have been 16 million, more like 10 million because the Supreme Court. Take it away. And the big debate you're reading about the past few days is how fast do we take it away? The original idea was in 1 year, then 3 years. Now Susan Collins is saying she might live with 7 years. Take it away by taking away the opportunity for states to expand, the ones that haven't, those 19 states that haven't expanded, end that, and let the Medicaid expansion money only apply to current enrollees. New ones can't have it. But Medicaid turns over. People leave Medicaid. They don't stay on it very long. There are people who lost their job for a while and they go on Medicaid, then they come back. My brother is one of them. And so the pool changes, and it means if you leave, you can't get back in. So over time, Medicaid, it goes away. Second, give to the states the opportunity to define the Medicaid terms. Remember things like the essential health benefits, what you have to cover, guaranteed issue. All of that gets returned to the states for their decision making. And the states like Alabama, what are they going to do? They're going to go, they don't have the money for one thing, and you're taking away the federal dollars, so they're going to regress to what they did. And the way we'll pay, it will be different. Right now, Medicaid, it's counter-cyclical. If there's a recession tomorrow and people get poorer, more federal money goes into Medicaid. It's counter-cyclical. And good times less, and bad times more. Now they want to take it away and do either what they call block grants or per capita caps. It's sort of the same thing. It's like the state only gets a certain amount of money, and then God bless you, go do with it what you can. We've seen that before. That's what free care pools were. And only nonsense happens. And the money they're proposing to put into that block grant, it won't cover increases in healthcare costs at all. It's so impoverished. It's silly. Millions of people would find themselves bereft in Medicaid, and many states would have to lower those eligibility limits. Medicaid expansion, gone. Exchanges, gone. Not quite gone. They're taking away the subsidies. So now the people who are just above the poverty line, they don't have the help now. Oh, wait a minute, we'll put in, instead of income-related subsidies, we'll put age-related subsidies, which everybody gets up to a pretty high income. But the age-related subsidies are rigged so that young people get more and old people get less. Now, wait a minute, who's sick? Whose premiums are going to be higher? So there's this immense transfer from elders who are going to pay much more. We're looking at increases for a single 62-year-old not yet on Medicare. The premium increases of $13,000 or $14,000 a year for people whose income is $20,000 a year. It's absurd. Young people get it. They get a little more subsidy. They're winners in the proposal. But overall, the country's a big loser. And the exchanges will fall apart. Because the way they're changing the rule base is no insurance company with a brain would go into a market under those circumstances. And they're fleeing now. You can see them getting out of it. They didn't flee when Obama was there. They're fleeing now because of what this administration is going to do to the insurance markets. I could explain more of that if you're interested in the wonkiness. And to make sure it happens, they take away the individual mandate. So now that 28-year-old immortal, they say we're keeping guaranteed issue 28-year-old, but you don't have to buy in till your car hits a tree. Now they say, well, we'll have a penalty if your coverage is not continuous. Nowhere near enough to cover the difference. They're taking away a lot of the requirements on insurance companies. They go dark again. Essential health benefits go away. I can be an insurance company starting after this law passed and not offer maternity benefits. As long as my state says you don't have to offer them, states have the choice, they won't offer it. They can drop maternity benefits. They can drop substance abuse coverage. They can drop autism coverage. All of that's required under the Affordable Care Act. Now those requirements are gone. What will happen is premiums will go down, but it's a shell game. They'll go down because you're buying a policy that isn't worth anything, which you can't do under the Affordable Care Act. On this side of the equation, they haven't declared themselves, but they're being very slow now about all this migration toward a better payment system. And believe it or not, they zero out the prevention money. Prevention goes away. And it's obscene. On the payment side, remember we paid for Affordable Care Act with tax changes that especially affected the wealthy? They're reversing them. Medicaid gets cut by $840 billion over 10 years. The president's budget adds $600 billion more to that. $1.6 trillion of cut over 10 years, of both $1.4 trillion, and $1 trillion of tax reduction for people of high income, over $250,000. It's the biggest shift of wealth from elders, middle class, and poor people to the wealthy that this country will have seen since I don't know when. All in what's being proposed. That's what they're voting on. It's vicious, and it's wrong. This is a country that has values. And as I told you, I think the stakes here are much bigger than healthcare, as much as I care about it. This is the sonnet by Emily Lazarus that is at the base of the Statue of Liberty. Emma Lazarus. It's called The New Colossus. You probably read it, and I'm sure they read it here in Derby Academy. She wrote in part, "Here at our sun-washed sunset gates shall stand a mighty woman with a torch, whose flame is the imprisoned lightning, and her name Mother of Exiles. From her beacon hand glows worldwide welcome. Cries she with silent lips, give me your tired, your poor, your huddled masses, yearning to be free, the wretched refuse of your teeming shore. Send these, the homeless, tempest-tossed to me. I lift my lamp beside the golden door." Those are the values. That's what's being threatened. It's not issues, it's not identities, it's the core of who we are. The golden door slammed on 16 million people who are too poor to get health care. The golden door slammed on elders who are going to find themselves in nursing homes with nobody to pay for it. The golden door slammed on our opportunity to invest in a nation and the health and well-being of our nation. But beyond that, it's only the most visible door right now that's being slammed. I mean, you think about the criminal justice system, an American travesty. This country should be struggling to return dignity and opportunity and self-respect to George Sanchez. If we can reduce prison recidivism from 85% to 15% in 20-year-olds who are in jail, why don't we just do it everywhere? That's the travesty. Slam the door on George Sanchez. The harm done to the planet by inattention to the facts of science, it's grievous. Call it a health problem. If desiccating the lands or poisoning the air, drying up rivers, drowning cities, not our cities and other cities around the world for people a lot poorer than us, a tsunami of displaced people that will be climate refugees. If that's not a health problem, you tell me what is a health problem. I think leaving refugees at our gates slammed shut, or children unfed, or families unhoused, or basic medical care uncovered, relying on conflict instead of compassion, that's a health problem. War is a health problem then. Ignorance is, hopelessness is. Blaming blameless people is. This, to me, is about justice. It's about compassion and justice and equality in our world. We can and we should fix health care, and we should struggle to do that, and this law is so wrong. But we will be making a mistake if we regard it as an isolated issue in any sense at all. This is a time for reassertion of who we are, not death by suicide, the golden door. And it's going to take a lot of work. I think I'll stop there, and I've got more to say about healthcare. I can go on for a 30-hour course, but maybe we should stop and you guys have any questions you want. Go ahead.
So you ended on a kind of a little bit of a downbeat note. What would you suggest we who care about healthcare in this country do, and in this Commonwealth? What would be your suggestions as citizens to do to try to make a difference?
Well, in a way, in a sick way, we've been given a gift, the gift of mobilization, of anger. I mean, this is not the world I want to hand my grandkids. Not the way it's being designed now. So let's recognize that energy. I think it would be important to come together. I know this is specific enough, Don, but I'll get there. I worry about us being divided into the whale people and the tree people and the healthcare people and the criminal justice people. That is not good enough. This is about the compassion people, the golden door people, and we've got to unify on the progressive side. And that unification's got to include that $50,000 a year carpenter in southern Ohio who voted for Trump and is now going to lose any possible access to health care. We've got to, and they're in Massachusetts too. I met him when I campaigned. And we got to broaden this tent and start to remind ourselves of values. I think that values discussion has to be had. It isn't good enough, though. There's got to be organization here. And I'm from the 60s, and I remember the architecture in the civil rights movement, and the architecture of the anti-war movement, and there were organizations, and there were events, and there were tactics. We had plans. We had leaders, and we've got to find them again. We're going to have to get organized, not just mobilized, and I think that's really, really crucial. Now, there is a political side to this, which is we've got to become very vocal citizens. Congressmen, senators, they listen to their constituents. And you know what? In a way, Massachusetts doesn't matter. We've been written off by this administration, by the Trump administration. But if you know somebody in Ohio today, they should be yelling at Rob Portman. If you know someone in Alaska, they should be yelling at Lisa Murkowski. And Maine, it should be Susan Collins. In Nevada, it'd be Heller. And in Tennessee, it should be Alexander and Corker. And these are people with brains. And they need to hear from constituents who just start to say no, not just on health care, but on this other stuff, and remind us who we are. I actually think there is a plan there, which is it's the plan of networking, of knowing who you know in the states where there are Republicans who need to be reminded that this is not going to be okay. And I would say that's important. It's important today and tomorrow as these votes start to take shape. I don't want to get too political in the state, but I think we should be taking Governor Baker to task as well. I think he's popular. He's done a lot of good stuff, but we've got to be the beacon, mother of exiles, and I think this is a state whose legislature and executive should be told, bring us to the destination we want for the nation, not get by, not just sneak through, not keep them happy in Washington. I think we're better than that. So I think there is a local agenda there. I think it resounds. If you ask me right now, to me, the bellwether, the measure of success is criminal justice. Why is this state not got the best criminal justice reform in the nation? We know what it looks like, and we have a House and a Senate that are sitting on their hands on this, and it's not okay. And I think we should pick a few like that and say let's get this done. Let's show what's possible upstream against the. So Dawn, I know that's not as specific as you wanted, but it's acting. Let me say one other thing. We don't know how this is going to play out. Medicaid in the state's crucial, and on just one pure issue, which is we are in transition in Medicaid in the state with a federal waiver to a much better way to deal with our very stressed Medicaid population. If the rug is pulled out by federal defunding, this state's going to have some very hard choices to make, and we may need to be generous. We may need to go back and say, no, if the country's in the wrong direction, we're not going to go in the wrong direction. We're going to go in the right one, and that's going to involve investments. Yes?
I'm reading a book by Dr. Rosenthal, American Sickness.
Yeah.
She makes a big point that medicine has become so profit-driven, especially in the last 10 or 15 years. Do you ever see a place for more salary providers and it's comparable to the permanente and that type of thing?
Yeah, this is a policy area. So the symptomaticity is there. I mean, when I was a medical student, I guess I generally trusted the institutions that I was in a relationship with. Their basic compassion, their putting of community interests before their own interests. Today, it's different, and it's different even in this state. The symptoms of organizational gluttony, of organizational self-interest are everywhere. It's not bad guy, good guy, because the organizations are good too. They're trying to do something they regard as noble. But it's myopic. They don't see their effects on the greater society. And that's because of the way we paid them. But those symptoms are everywhere. Now, the worst is the pharmaceutical industry. So the drugs that our patients depend on are experiencing price increases that just they don't withstand the scrutiny of public interest or moral compass. Biologics, the things that now cure hepatitis C, for example, unquestionable value, they're being priced at levels that aren't like extortion, they are extortion, because the companies can do anything they want with these prices, and they do. Even old drugs that I used as a medical student, colchicine and 17-hydroxyprogesterone and epinephrine and insulin, these prices are going up quarterly. So there's a confiscation going on, a real one, by the pharma industry just because they can raise prices. And they wave their hands about American ingenuity and we're the font of great inventions and shouldn't we value price things. We need to say no. And if the federal government won't say no, I think the state should. I think we've got to get some pretty aggressive ideas in this state about reimportation of drugs, about any way we can control drug pricing. It's largely a federal issue, but I would really look hard for a way to stop it. The hospital behaviors, I'm speaking now on my own. I'm a member of the Health Policy Commission. That is not who I'm speaking for right now, but we have taught hospitals in this nation to play a game, and it's a revenue maximizing game. Get all the money you can. And remember, these are good people trying hard to do the right thing, taking the money away from George Sanchez, but that's not what they see. And we're going to have to get some backbone here and say to these very fine hospitals, you're wonderful, but you can't have that. Not with $1 trillion of waste in the system. Get with us on this. You work on the reduction of waste so George Sanchez gets a GED. Or so a baker in Pittsfield can keep in business, because it's affecting small businesses more than any others. And I think we need more teeth here in this Commonwealth to deal with that, so we can put the money into schools and roads and housing. We're 1 million housing units behind in the state of Massachusetts, 1 million. Where's that money going to come from? So I think this fighting the kind of unfairness that's gotten out. Libby Rosenthal's book, which you all should read, it's pretty polemic. I mean, it just says this is all a conspiracy. And you could almost buy that. The one thing I think is Libby I don't think she's giving credit to the good people that are trapped in the system too on the provider side. They're really They're behaving the way they're kind of caged to do, and we need to change the rules around it.
On the issue of drug importation and negotiation of Medicare being not allowed to negotiate the price of drugs and so on, are there things that if we are focusing on Massachusetts to protect ourselves from the impact of the national level activities, are there things that we could do on the pharmaceutical front or on the broader legislative front that would protect us here?
The answer has to be yes. I don't think we know the details of that right now, but I think it's a wonderful question and is the kind of thing that if I were in the legislature or executive, I would charter. I'd say we need an answer, and we need one with teeth, with muscle in it. And by the way, believe me, the good pharmaceutical industry that is invested in Massachusetts, the good medical equipment manufacturers, they're going to cry. They're going to say no. That's where the guts come. You can't be wasting $1 trillion out of $3 trillion without somebody making money on the waste. And when you say, no, Gorje Sanchez needs that money, you're going to have a political battle on your hands. But we've got to have those battles. This is a public who understands that its self-interest lies in a kind of discipline and forcefulness that we don't have. Now, what could we do? I don't know exactly. I think states might get latitude to do some drug importation. I'm not sure about that, but I just do not buy that my friends in Toronto and Montreal are being subjected to risky medications any more than I am. I just don't buy it. Maybe I'm wrong, but I think we should look hard into that and what legal options we have. I think any way that we can begin to threaten price controls at the state level, we should be doing. And I think that the other side is the utilization side, because we have pharma, for good reasons, they're out there marketing everything. You see, turn on your TV, and you'll see all the drugs being marketed. We need a state plan for the counter-marketing to say, no, this isn't helping you public. This is taking money and health from you. And I think there'd be a plan possible at the state level.
One of the things that has gotten attention, and there are some bills in the state legislature dealing with this right now, are Medicare for all, single payer, something that moves in that direction. And I'm wondering if you could address that issue in terms of, the premise behind it, one of the premises behind it, tends to be that there is an enormous amount of financial saving if you can get rid of the layers of overhead that are built in. So let's hear you address that directly.
Okay, this is a single payer issue, and Jamie Eldridge has a bill that he's brought up every year on single payer at the state level. Vermont tried and failed a couple of years ago for reasons I could describe to you. Let me give you the basics. I'll try to be really fast about it. First of all, what is single payer? What does that mean? It means this. If you follow the money in Massachusetts, the United States, and how it gets into the hands of people that give care, it's many, many streams. Medicare, Medicaid, Medicare Advantage, commercial insurance, free care pools. There's just this spaghetti of payment. And on the commercial side, it isn't just one payer. It's Cigna and Aetna and Blue Cross and Harvard Pilgrim and Tufts. So you're managing streams of money that are very complicated. Every one of those streams has rules attached to it, what's covered, what's not covered, what forms you fill out, where you send the form, what the coding is, what the coding can't be. It's a mess. And if you follow a nurse in a hospital today, you should do it, or follow a doctor through her office, what you'll find is they're spending a lot of time and energy managing that, filling out forms, figuring out the codes. Hospitals have desk after desk after desk of clerks just trying to figure out how to make the coding system work. That's waste. That's waste. The job isn't waste. These are good people in jobs. And one of the things to be very careful about if we ever try to simplify that, remember, there are thousands of people in Massachusetts whose jobs would go away. And there's got to be a soft landing there. We can't just do that to people. But let's call it what it is. It's wheel spinning. The other thing that happens with that complexity is there's no voice. Now let me give you an example. I ran Medicare and Medicaid for President Obama until the Senate refused to confirm me, but I was the administrator. So one day, Dan Levinson, the Inspector General from HHS, sent out a report, reached my desk, and it said, in America, they estimated, based on very, very detailed work they did, that there were about 300,000 people in nursing homes who were being over-sedated It's illegal to tie someone down in a nursing home, but you can use chemical restraint. And they found about 300,000 people, is their estimate, of people with antipsychotic medications they shouldn't have gotten who were zonked. They get pressure ulcers, they aspirate, get pneumonia, they can't say hello to their grandchildren. It's bad. So I went and visited Dan, and I said, what's going on here? And he walked me through the stuff. So I get back in my office, and I pick up the phone, and I called the Association of For-Profit Nursing Homes, the Association of Not-for-Profit Nursing Homes, the Association of Geriatricians, the Association of Geriatric Nurses, and others. And I said, I'd like to have a meeting now. And within a day, they were in my office. We were sat around the table in the administrator's office, and I held up the report. I said, 300,000 people in near coma with drugs they shouldn't get. You stop it, or I'll stop it. I could say that because I'm paying them. I'm paying for the care of 50 million people on Medicare. I'm paying for the care of the people in those nursing homes through Medicaid. So they showed up. And you know what they said? Yes. And we actually ended up with a wonderful program in CMS to work with nursing homes all over the country with these agents to reduce it. And we have had the sharpest reduction in use of antipsychotics in this country over the past 3 to 4 years in history. We just had the report just accepted by the Journal of the American Medical Association that reports this out. Why? Well, I'm not being arrogant about this. I had plenty of help. Believe me, nothing of this could I do alone. But in a way, we were the single payer and we had voice. Now, we had an opioid epidemic overtaking our communities. We have serious problems with advancing dementia in our Commonwealth. We have problems of risk. Who's going to say to the delivery systems, you need to work on this, everybody? Come to my office, we're going to organize. Nobody. Harvard Post's not going to say that. Tufts isn't going to say that. They're good people, but they don't have the force to say it. You get a single payer, one place doing the payment, you get voice back, and you get representation back. The public does. Because when I'm in that room with those geriatricians and those nursing homes, I have only one client in that room, and that is the American public, and especially the Medicare and Medicaid beneficiaries. I speak on their behalf. There's no such dynamic. So single payer gives you administrative cost reduction because it's far simpler. It gives you voice. You can set agendas, by the way. You can then say, this year it is opioids, and there's a lot of the good stuff, but let's focus our energies. You get transparency and clarity. You call your insurance company and ask them the prices of stuff. They can't tell you. Medicare can. It has to, by law. We have to post where the money's going. So the transparency, the negotiation power, the accountability, and the overhead are better. My overhead in Medicare was technically 1% of the budget, $800 billion, $8 billion administrative budget. Maybe we're miscounting. I always say maybe it's 3%. The overhead in American healthcare insurance is 15 to 20%. In Massachusetts, by law, it's 10%, but that's a big difference between 10% and 3%. So that's single payer, a stream of payment that would go through one channel. It would sort of have to be governmental. It's hard to think of another way to channel the money. I suppose we could do it with some utility structure maybe, or something like an authority structure, so it's sort of arm's length from government, but one stream of payment. Could it be done? Yeah, it could be done. Other countries do it. Some do, some don't. And it's not a precondition. There are countries that have high-performing systems without single payer, but the ones that do are pretty interesting to work with. Sweden, England, Wales, Scotland. And I think we could try it at the state level. Big confusion. Sometimes I'd go into a living room when I was running for governor and we start talking single payer, but it would be immediately clear to me that most of the people in the room thought that meant government owns the health care. It employs all the docs or owns the hospitals. That's what is true in England. But no, that's a separate choice. There's the choice of how you pay for it and the choice of who works for who. Back to your question about the circumstances, I'll tell you, in circumstances where the doctors and the hospitals are working with a population budget, whether it is single payer or not, where they have a budget for care, everything gets better. The gerbil cage stops spinning, you can reallocate, you can send someone into Johnny's home to clean the house instead of treating his asthma attack, because you can move the money around, and that's an advantage. Boy, I'm sorry, it was a long answer, my God.
Employer providing healthcare, which I'm very grateful. And I had a couple of theories, but you probably have some facts about why other industries don't get behind provide health coverage for their employees, and it's getting more and more difficult. And why aren't they doing the fight?
The fight for what?
For universal vacation.
Yeah, I don't know. I mean, if you could snap your fingers and get there, it would be better. Everyone's better off, except the people employed by the waste. We have to have a soft landing for them. But yeah, I mean, General Electric Corporation is paying a ton of money for its coverage of health benefits, and it has no control over those expenditures. It can't do anything about them. You'd expect that. You'd expect a unified front that would say, wait a minute, let's do it one way for the country, but that hasn't happened. And I think it's probably people feel, I mean, we have a country that fears big government. They see the downside of that. There were bureaucracies and inefficiencies in government itself. And we on the left, we have a job to do, which is to also say government has to do it right. We are accountable. We have to act accountable. But I don't think that trust is there right now.
My premiums and deductibles go up every year, so
You bet.
people with good coverage are taking a hit, and it's getting more difficult. And maybe these companies these corporations have set a limit, and they just passing it down to the employees.
Yeah, the statistics are showing that more people are paying more and more out of their own pockets. They're paying it in co-pays and deductibles. They're paying in a higher share of the premiums, even if their employer covered. They're paying it in low and less generous coverage, where the things are starting not to be covered in the. That's the trend in the country. That's one of the cost containment. If you're a big employer and it's eating your lunch, like it's eating Gorje Sanchez lunch, then you feel like you have to do something, and so you cut. You cut. What they should be doing, what I wish we were doing, is mobilizing for redesign of care and efficiency in payment, but that's not what's going on. There is a theory here. If you go to most of those employers, oh no, people need more skin in the game. If you have to pay a higher copay and you have to pay a higher deductible, and you're going to be much more sensitive to costs, and you're going to realize that you could get your hip replacement done in a community hospital and get the same results as you would at Mass General or the Brigham, which is true. I don't think it works that way. I don't think people are really that sensitive to the prices, and I've never really believed in that approach, but that's what you're hearing. It's more skin in the game, your skin.
That'd be nice if you could actually find out how much it's going to cost.
If you actually could find out the prices and find out the cost and find out the quality, then maybe it would start to work, but we're nowhere close to that. It was interesting, in the Affordable Care Act, there were lots of regulations that we had to issue on transparency. Now, they got blocked repeatedly. The lobbyists would come in and say, no, that calculation's wrong, you can't count it that way, or we need a delay. So the combat went on. We actually had authority to do a little bit what you're doing. Give us more information.
Don, your college roommate, Bill Beard.
Hey, Bill! Is Kathy here?
No, she couldn't get it. Two questions. I think I heard you on a talk program back in the February-March timeframe when this issue of where we were going with ACA was going, and you seemed quite optimistic that there were breaks that would slow and prevent the ability of a Republican Congress to take this apart quickly. That it would take time. There was time built into the way ACA was built originally. So that's one element that I'd be kind of interested in how, because now you seem more pessimistic about it. And the second piece is, I think some of us have been hoping that the disarray among Republicans and the fact that the Congress, the House and the Senate cannot agree on which elements of ACA they do want to retain, that maybe they just won't get their act together, so this trend can get stopped. I'd be interested in your perception of how things changed in the last couple of months.
Well, let's do the second question first. How have things changed? What's gone on here is, I want to be polite, but I don't feel polite. The Republican leadership, Ryan and McConnell, they're buying off one vote at a time by tweaking elements of the proposed bill to get Senator Collins on board, to get Cassidy on board. Each has a thing that is just enough to get them in. The latest thing you saw is on the Medicaid. Remember, take away Medicaid is delay taking away Medicaid. So now what Collins has said is, I'll go with 7 years. We'll get rid of the Medicaid expansion over 7 years instead of 3 or 1. That's a buyout. Stuff around the size of the subsidies. Just a little bit more gets Cassidy on board, a little bit less. So they're buying people. Of course, this is like, it's a bit like a Swiss watch. I mean, the Affordable Care Act's not perfect. And a good conversation to have is, what 10 changes would I make in it to perfect it? We know what they are. It's actually not even that hard a conversation. But when you start doing these tweaks, the thing gets more and more nonsensical. And that's what burns me the most, is the irresponsibility of this concoction of the American Health Care Act. It makes no sense. There's no logic to it. There's logic to the Affordable Care Act, as complex as it is and as imperfect as it is. There isn't any logic left to this buying off. The buying off is working, though, and it appears to be. We don't know until the vote's taken. What will happen if they send it over to the House then? Well, when I said in that interview, if you're remembering, I guess, it was, I don't think the Affordable Care Act would go away. I thought, number one, it's too complicated. Look, we had many I oversaw the issuing of dozens of regulations. I mean, this changed the definition of healthcare through essential health minutes. It changed if you go into Burger King now and you look up on the wall and it says hamburger 700 calories, that's in the law. It was required. That's in the law. There's stuff that affects the experiments we're doing with accountable care organizations and bundled payment and community-based care transitions and prevention initiatives. This is a lot happened in 7 years now since that law was passed. I thought, you can't take that away. How would you disassemble it? It'd be like unknitting a sweater. But they're willing to they're more willing than I ever thought they would be to just take mixing metaphors, but a sledgehammer or something, and just wipe it away as if there wasn't a bunch of secondary effects there. I just didn't think they'd be willing to do that. More than that, I know how many Americans benefited from this law. It's not perfect, but it's progress. We've got 10 million more people on Medicaid. We've got 10 million or so more people covered with those exchanges. We have much better prevention coverage for absolutely everybody. We have kids under 26 covered in their parents' policies. We have millions and millions of Americans who they don't have to wake up in the middle of the night knowing they'll go bankrupt if they get sick. Millions. And people know that. And now they're going to take it away, and they're going to take it away. They're going to try. I didn't think they'd have the gumption to do that, and I thought the American public at this point would be a little more aware of what they're losing. Indeed, if you read the polls, they are. So now the support for the Affordable Care Act has vastly crossed a majority, and if you take elements like guaranteed issue and the existence of the exchanges and even the Medicaid expansion, the majority of Americans now support it. What's happened is, in this political environment with the extremism that we have, they don't care. It's inside baseball. So Bill, I called it wrong. I hope I didn't call it wrong. I hope we're still going to see this thing not happen. They boxed themselves in because they made it their lead issue. They said, for day one, we're going to stop the Affordable Care Act, and they're afraid they're going to look like they betrayed their base if they don't do something.
Can I get here? I just need to know, why did Vermont chicken out? I was so disappointed.
It's so interesting. I mean, the states as laboratories of democracy, we have a lot to learn. So Vermont, the governor backed off it for 4 or 5 reasons. I can't remember them all, but I'll tell you a couple of the big ones. Here's the biggest one. Let's say we went single payer. So now we have, in this state, I think we're spending about 32 or $33 billion a year on healthcare. Now we're going to channel that all through one pipeline. Well, how do we do that? That money's going through, like, employers are paying some of it, the Medicare is paying some, Medicaid is, you're paying out of pocket, all these channels and multiple insurers. But if we're going to channel it through what Vermont said, we're going to do it with taxes. We're going to, instead of all that money coming out of your pocket these ways, it'll come out of your pocket one way, which is taxes, a payroll tax and an employer tax. So they converted a non-tax system to a tax system. at lower cost in aggregate, but that's not what the headline said. Largest tax increase in the history of the Republic. Because it is, if you want to call it that way. The fact that it overall saves money or is better for you, or you can guarantee coverage, or we save tens of billions of dollars on administrative stuff, that didn't cut the mustard. So that was the first loss, largest tax history, largest tax increase. We're going to have to find a way, if we want to go there, to explain it to the public in a way the public says, yeah, I get it. Vermont has some other anomalies, many small businesses that don't provide coverage. And part of this law was to go to universal coverage. And the small businesses, they didn't bring them on board. The subsidies that essentially been going from large businesses to small businesses would have ended. I think it was a defect in the way they designed it, but that's the way they designed it. A third problem was Medicare wouldn't play. Medicare said, you can have a single payer, we're not going to join the single payer. That meant immediately you had a dual payer. And that was a problem. A fourth problem is it's the ERISA law, if you know what that is. It's a really silly law in our country that says if you're a self-insured multi-state employer, like GE or Raytheon, the state can't regulate your insurance. It's federally preempted. So when Vermont says, hey, everybody's going to be single payer, if the big companies say, no, ERISA protects us, you can't do that to us, there's nothing to do. They would need an ERISA waiver from Congress? Not likely. So those were some of the reasons Vermont failed. They're all lessons learned. We're hearing, California is interested in it again. I think we'll see other states. It'll rise again. And Vermont's returning to the topic. So it's a learning process.
I wondered what the role of the American Medical Association is in reaching some sense of inclusion for our health.
The question is the role of the American Medical Association. Well, I'll say first, their CEO, Jim Madero, is a friend of mine, is a terrific guy. I mean, he really wants to see healthcare become what it can be, and I have enormous respect for him. But it's a guild, and it funds itself with dues, and dues play to the center. And the bulk of the members of the American Association are specialists who are doing very well, thank you, under a volume-based payment system. And so they've not been the leader in saying we need to go here. They did eventually come on board the Affordable Care Act. They supported it. But then when Tom Price, bitter enemy of the Affordable Care Act, got named by Trump to be HHS secretary, they immediately sent a letter of congratulations and welcome. So I think they're kind of trying to go down the center of the street. I wish all of us would say, no, golden door, send us your tired, your poor, from inside and outside. And I would look to us to do that. Maybe one of the answers to Dawn's question is if at the state level, we have a state medical association, we have a state hospital association, we have state dentists. We could say in this state we talk different. And I think that if you're in any of those professional groups, get us going.
We have take one more question here.
Yeah, I can't.
I'm over here.
Where?
On the other side. There.
Oh, there. I don't want to steal your time, but I will for a minute. There's one issue, by the way, there's one little issue, I think it's still in the legislature, you can tell me, Representative, but it's a dental health therapist. Do you know this story? Okay. I worked in Alaska. Remember, I saw patients in Alaska when my wife had a sabbatical there. The dentists, there aren't enough dentists to treat Alaska, so they have dental health aid therapists. They're like physician's assistants in dentistry. Dentistry doesn't have any mid-level, but these are mid-level, and they can fill cavities and do dental prophylaxis. It's a great invention. It was been adopted in I think, Minnesota, Maine, just did it. It's in 53 countries. It's been heavily evaluated. It shows better care at lower cost than the dentists give. In the state of Massachusetts, we have 290,000 children on Medicaid who haven't seen a dentist in the past year. 290,000. Only 1 out of 3 dentists accepts Medicaid at all, sees even a single Medicaid patient. We have a big unmet need. Nursing home, people lying in nursing homes, they don't have dental care, and that's really bad if you're a frail elder. So Senator Harriet Chandler and Representative Smitty Pignatelli proposed a bill last year to have dental health aid therapists in this state approved as a new discipline. So we can get this done. High quality, lower cost, fuller coverage, and better for dentists. And it passed the Senate 39-0 and lost in the House. We're better than that.
I can work on that.
Let's do it this year. I mean, there is no reason why we wouldn't. It's the golden daughter oral care, and just like NUCA, when you configure care properly, it gets better. It gets lower cost and higher quality. I think this state should be out in front on dental health aid therapists, and that bill is still making its way through.
So I'm going to have this woman ask the last question, but I was told by a woman on the other side that there is a 12-minute YouTube video that you did on the Institute of Health Care Quality site that explains the Affordable Care Act really simply.
Yeah.
So maybe you want to make a plug for that.
Okay. Well, I spend part of my time now as senior fellow at the organization that I founded, the Institute for Healthcare Improvement, IHI. So if you go to ihi.org, and then search for a YouTube video of me speak. It's what you just heard, but shorter. Probably, why didn't I do it shorter here, you might ask. But I think it's about 18 minutes, and it explains ACA and HCA as of about 2 or 3 weeks ago. And just, you can use it. It's public domain, anything you want. Yeah.
Hi, so I'm with seniors in long-term care. Long-term care is very, very, very expensive. And most of our elders really have no choice but to turn to Medicaid. It's almost impossible to pay for long-term care by yourself. So what is baffling me, and I'm wondering if you have any perspective on this, is the Republican tenet, generally speaking, is self-sufficiency. And there's complete silence right now as to self-sufficiency for long-term care, such as the payroll matching that they do in Germany or shoring up the long-term care insurance industry. Do you have any perspective on this complete silence?
Well, right now the safety net is Medicaid. 1/3 of people in nursing homes are on Medicaid, so people think Medicaid's about poor people who won't go to work. No, it's a lot about your mothers and fathers. And John Gruber had an editorial in the New York Times this morning that Llewellyn and Dawn showed me. I read it, which makes that point. It's us. Long-term care is an unsolved problem in our country, to say the least. The way we deal with elders and frail elders, we have wonderful examples of community-based supports that keep people at home and out of institutions for a long time, and we should be maximizing that. In the Affordable Care Act, you saw a line there, community-based care transitions. Thousands, millions of people potentially going from institutions to home with proper support. Republicans zero it out in the Health Care Act. So there's innovation answers to that. But in the end, it's going to be, it's back to this question of what kind of country we want to be. And there are models around the world of far more compassionate, committed ways to help elders. You know, one of the sad things here, I want to leave this on a high note because I do think I'm glad to be back in the 60s and mobilized. Let's get organized now. But if suppose this hadn't happened, suppose like we had sensible Republicans and sensible Democrats saying what's next, and we built on the beauty of what's been done in the Affordable Care Act and fixed its dark spots. You know, what are some of the stuff we could do? And the answer is there's a list. There is a list. You've named one of them. We can now get about the long-term care problem. We tried. The Affordable Care Act had in it something called the Class Act. There was another law which was basically insurance available for long-term care. It didn't work. Actuarially, it didn't work. We had to stop it. Obama withdrew it. But if we got about that job and the opioid job and fixing the subsidies and taking the waste out of the system and dealing with the farmer pricing problem, we've got a long list of stuff this country is absolutely up to managing if we didn't waste our time in this vicious assault on justice. And we need to get our head back on our shoulders. Well, thank you. It's been a pleasure to spend time with you.